Thank you. Well, thank you, Overcome, and everyone out there for being here today. I think this will be a little change of pace from the prior talks this morning, but we're going to be focusing on a very specific rare form of ovarian cancer today called granulosa cell tumors, and I'll try to provide some insights and background into how these differ from maybe other diseases that we treat, and some of the more cutting edge developments that are on the horizon for this tumor type. Don't have any disclosures. So I would like everybody to know today, that rare types of ovarian cancer, particularly granulosa cell tumors, require unique and personalized treatment approach, and that I personally try to show my support for this community by being accessible for second opinions and virtual consults, and together by staying involved with organizations that do great work like Overcome, we can continue to grow and make progress, move the needle for patients and families affected by this disease. So just to start off, I use this analogy sometimes in clinic. Granulosa cell tumors arise from the supportive structure of the ovary, which is quite different than more common types of epithelial ovarian cancer like high-grade serous. The analogy I use is of an orange. So the orange has a peel, and the vast majority of ovarian cancers arise from that epithelial peel. Now, the granulosa cell tumors arise from the actual substance of the orange, the fruit itself, internally. So quite different in terms of the biology, quite different in terms of the age of onset, most often in the 40s and 50s. And although it's sometimes considered cured by initial surgery to remove the ovary, relapse is very hard to predict and can occur even years or decades after initial treatment. So some unique challenges with this disease.
Dr. Hillman, if I could stop you really quick, I apologize.
Yes.
If you have any slides that you're going to be sharing with the people, can you actually go ahead and share your screen, please?
Oh, I am sharing.
Yeah, we are seeing it. We are seeing his full
We are
screen.
seeing it.
I know. Yes.
Perfect. Thank you.
Okay.
All right. There you
So symptoms of granulosa cell tumors are actually quite different because they're very frequently early stage at the onset. So, they rarely cause kind of systemic constitutional symptoms like bloating, weight changes, changes in bowel or bladder function, but they do often produce quite a bit of excess estrogen. And so they frequently come to light because of abnormal uterine bleeding caused by this excess estrogen, which can also actually lead to uterine cancers and precancers. They're very frequently just on one side, just affecting one ovary. And it's important that if abnormal bleeding is present or there's other risk factors, that part of the evaluation include a biopsy of the uterine lining to make sure that the granulosa cell tumor hasn't also caused problems with uterine cancers or precancers. So surgery is by far the mainstay of treatment for initial diagnosis. So if fertility is not a concern, if we're past childbearing, then often this involves total hysterectomy and removal of at least the fallopian tubes and affected ovary with additional biopsies of the omentum and the peritoneum. This is a unique disease in that there's a good data showing there's extremely low rates of lymph node involvement. So with other forms of early stage ovarian cancer, we often need to perform a complete removal of lymph nodes in the pelvis and up by the great vessels, but that's rarely, if ever, necessary for granulosa cell tumors at initial diagnosis. Now, granulosa cell tumors are also quite unique in that they have a very specific molecular alteration. So these are nearly always positive for a specific mutation in a gene called FOXL2. Now, this is not a genetic lesion in the same sense that BRCA1 and 2 cause familial risk for cancer. So this is specifically something that arises in the tumor. And we're beginning to shed some light with my lab and others on what the mechanism of this mutation is. But as of right now, we do not have any therapies that can target this, despite how ubiquitous it is in granulosa cell tumors. Now, this is not for lack of trying. So our group actually published the largest series in collaboration with Foundation Medicine, looking at the molecular profiles of granulosa cell tumors. We were really trying to see if there were other targetable mutations or biomarkers that we could identify. So things we looked at were conventional biomarkers for immunotherapy, such as tumor mutational burden, PD-L1 status, and microsatellite instability. And none of these were significantly positive in our series of about 420 granulosa cell tumors. And aside from very rare mutations in genes like PIK3CA, there's very little that we can point to on these molecular profiles that would sort of readily allow us to utilize any targeted therapy that is out there. So I think this result, to me, provided a lot of motivation for making the FOXL2 mutation something that we can target and treat with therapies, because it is so ubiquitous and because we lack other promising targets in this disease. So some of our management for granulosa cell tumor really is driven largely by initial stage. So for stage 1 disease that's confined to an ovary, surgery is often all that's required. And this is the vast majority of initial granulosa cell tumors. For advanced stage disease, so that has spread beyond the ovary, national guidelines and just reasonable oncology practice supports the use of adjuvant chemotherapy because the recurrence risk can be quite high in this setting. Now, where there's controversy and where I really encourage folks in this situation to seek multiple opinions and really kind of decide for themselves what they prefer is what we call stage 1C. So if there's sort of cells in the fluid of the abdomen, or if there's involvement of the surface of the ovary, my general practice is to recommend chemotherapy in this setting. And this recognizes, though, that there's data from Europe and data from the United States that show that this does not result in any sort of advantage in terms of living longer. But we do know the recurrence risk for stage 1C disease is quite a bit higher than for stage 1A disease. And chemotherapy is effective in a subset of granulosa cell tumors. And so it is what we have to offer. And I do think that it does help in this setting in some situations. But, has it been proven definitively? It is not yet. There's not yet data to support that. It is not sort of a standard of care. So this is certainly an important point of discussion if you find yourself or a family member in this particular situation. Now, surveillance usually takes the form of regular clinical visits up to 5 years, even though recognizing that some of these recurrences for granulosa cell tumors can occur after 5 years. I think the record in our data set at MD Anderson was about 21 years after initial diagnosis, so quite a bit further in the future. So luckily, though, we have some good blood markers, and these include predominantly inhibin B, but also inhibin A and anti-Müllerian hormone, which is AMH. So those should be incorporated into surveillance because they can often give a clue as to whether we should be suspicious about an early recurrence if they start to rise. Now, AMH is often very tightly correlated with inhibin B, so the two of them tend to be useful together because they will rise and fall often during surveillance. So I think an area that my lab and group have spent a lot of time working on is sort of trying to puzzle out what are the best practices for the management of a first recurrence, because that's really, I think, the clinical challenge before us is what to do when this disease comes back and how to get the best outcomes we can from the treatment options that we have. So often the sites of recurrence are, other locations within the peritoneum or the lining of the abdomen and pelvis, sometimes in the liver or omentum if it remains, and then the blood supply and the connective portion of the intestine or the mesentery. So surgery has often been used historically for this situation of a first recurrence. But before we came along, there was very little data really about the effectiveness of this, especially as you get beyond, the first recurrence into the second and third recurrence. And so that was something I looked at with the fellow, now faculty at MD Anderson, Jeff Howe. And we published on our results showing that there's actually a benefit in recurrence-free survival extending into the third recurrence for using surgery to treat this disease. So In addition to some of the systemic therapies that I'll mention in a moment, being evaluated for the safety and effectiveness of surgery at a expert referral center, I think, is a key part of receiving optimal care for recurrent granulosa cell tumor. Now, I have some particular practice patterns that I've learned out of having a lot of experience with this disease. So I usually try to recommend at least 12 months between surgeries for recurrent disease. This isn't a hard and fast rule. It's just if we're needing to think about surgery with less than a year after the prior attempt, I worry a little bit that the benefit may be outweighed in some cases by the risks and recovery time we may be incurring with the surgery. And, in other forms of cancer, surgery is very rarely used in the recurrent setting. And usually if it is, it's used in conjunction with effective systemic therapy. I think paradoxically, sometimes I will consider surgery if we're actually experiencing progression on a systemic therapy, because it can be effective and allow us to continue using hormonal regimens by reducing the amount of disease that's present and extending the time on treatment. So there's some pretty unique aspects because surgery can be so effective at extending the disease-free interval for this disease. And in the past, I've used a multidisciplinary team that's included surgical oncologists and sometimes even chest surgeons, thoracic surgeons, when we've had to remove disease from around the lung. Now, I wanted to show this slide, not for the details, but to really show the acceleration and the progress that's being made in clinical trials, looking at different systemic therapies for granulosa cell tumor in particular. So historically, you see a lot of purple. So you see chemotherapy regimens into even quite late into the 21st century being the mainstay of clinical trials. And this led to an evolution in our practice using carboplatin and Taxol. But if you look in the more modern era of what's really happened in the last 5 to 10 years, it's been dominated by hormonal therapy combinations. And some of these have not really lived up to our hope, but I think this is the active area of investigation, is how to utilize the blockade of estrogen, progesterone, and androgen signaling in various combinations that can result in effective treatments for this disease. So historically, hormonal therapy was thought to be highly effective for this disease, but one of the problems with the data, and I'm showing one of the really seminal papers here by Van Meers et al., was a lot of this data was looking backwards. So it was physicians or groups kind of gathering up patients that they may have treated with these various hormonal agents and then publishing on the success rate. And you can see, I think this table is really interesting because over in the response proportion for drugs like anastrozole and letrozole, you see a lot of 100% responses. And, I just know from clinical experience that that's just not generally what we see. And I think this was really borne out a few years ago when finally a prospective clinical trial was published called the Paragon study, which looked at 41 granulosa cell patients who actually were estrogen receptive positive and received anastrozole, which is an aromatase inhibitor. The actual 12-week response rate was just over 2%. And this increased a little bit with further observation, but quite a bit different from these backwards looking retrospective studies that probably had significantly overestimated the effectiveness. Now, I don't think that this, and certainly I've not stopped using aromatase inhibitors, but I think when I start them, I think the expectation I try to set is we're looking to achieve disease stability with a minimal effect on quality of life. And the idea that we're going to see 100% objective response on our next scan, the disease will melt away, is probably not a realistic goal for most hormonal therapies in granulosa cell tumors. So I do often use both letrozole and anastrozole. I think they're equivalent as far as we know for the treatment of granulosa cell tumors. You have to do some things. You have to really, they can pretty significantly accelerate bone density loss. And so you have to be mindful of that and monitor it, because sometimes we spend, multiple years on letrozole. And there's some other kind of good practices for being on drugs like this, such as taking calcium and vitamin D and regular weight-bearing exercise. Yeah, the myalgias and arthralgias can be pretty significant, and there's really not a easy solution other than some of the supportive measures that I've mentioned here. But we often have had success if we switch to an alternative aromatase inhibitor. So if we're having trouble on letrozole, sometimes it's easy enough to switch to an anastrozole and make up some of that quality of life a bit. So one drug that was long used for this disease without really a clear mechanism of action. And then finally, we published on kind of our clinical experience at MD Anderson on the effectiveness of leuprolide acetate or Lupron. And it does seem to be effective and potentially even as effective as chemotherapy in the relapse setting, with certainly much better quality of life than platinum-based chemotherapy or Taxol. I usually give it as either a monthly injection or an injection every 3 months. There's no real data yet to suggest there's a difference in effectiveness, and the 3-month dosing is sometimes easier. And I'll very frequently team up leuprolide acetate with an aromatase inhibitor like letrozole. I think there's some reasons to think there's synergy, and I've seen that in the past in some cases. And then we can continue on the combination regimen for quite a while in some cases. There's been some other trials, which I alluded to on that prior slide, looking at for example, onapristone, which is an anti-progestin agent in combination with the anastrozole. But this trial was pretty disappointing with not only a 0% response rate, but a very short progression-free interval of 3 months. So pretty much as soon as patients were assessed, they were found to be progressing. So this is not an avenue that we often pursue. Now, more recently, there's been a national trial through NRG Oncology led by a colleague of mine, Libby Hopp at Wisconsin, looking at, it's a single-arm study called GY033 that looked at a combination of an anti-androgen, darolutamide, with exemestane, which is a newer generation anti-estrogen, plus leuprolide acetate. Now, the rationale for this was very intriguing, but unfortunately, although it rapidly accrued, it did not meet its criteria in terms of effectiveness to reopen for the second part of enrollment. So it was ultimately likely to be a negative study. But I think an interesting concept and really emblematic of the move towards hormonal combination regimens as the focus of clinical trials right now. And there's another published trial from Europe looking at another anti-androgen that similarly showed a very low response rate. So right now, off-label use of anti-androgens, I think the data we have right now for enzalutamide and darolutamide is sufficient to say that's probably not something I would generally pursue or recommend for most folks. Now, slightly more promising are, so breast cancer treatment for hormonal positive disease has evolved towards often combinations of anti-estrogen and with or without these CDK4/6 inhibitors, abemaciclib, ribociclib, and palbociclib. So there was some rationale molecularly for using these drugs in granulosa cell tumors. So a very talented clinical fellow in my lab, Alison Brodsky, spent her research years really trying to develop preclinical data on whether abemaciclib in particular would be effective in granulosa cell tumor models. And so this paper just came out this month, and it shows that at least in our laboratory models of this disease, abemaciclib is quite effective. And I've just shown the figure here of an animal study where it was very effective at reducing tumor mass in animals. So there's also some anecdotal data about these agents being used with some success on a compassionate basis. And so this is something I would consider, and we have tried to and been successful on occasion of getting insurance approval to use these agents for the treatment of granulosa cell tumors that have seen a lot of prior therapies. Now, I think really provocatively last year, there was a very small but very interesting clinical trial of combination immunotherapy with a CTLA-4 and a PD-1 inhibitor, ipilimumab and nivolumab. It was only 8 granulosa cell patients, but the response rate was 25%. So it was one adult type tumor patient with an adult type tumor and one patient with a juvenile type tumor. And these included pretty deep and durable responses, and one of them was a complete response. And so I think we're waiting, you know, really before widespread adoption to see some real world data on the use of this. But it's very provocative, and I have recommended it in some cases where we are sort of limited in our options or have done most of the other treatments that I've mentioned. And we're sort of just waiting for more information to see where this should fit in terms of, you know, using it in conjunction with hormonal therapies and how to put things together in terms of sequencing different treatment lines. So I would like to end with kind of a story that came out of my lab that represents, you know, 5 years of work by most of the people listed on this paper. It was published last year. Some of you may have heard of this. It's looking at the FOXL2 and our discovery that actually glucocorticoids like dexamethasone actually drive the growth and proliferation of these tumors, and that, you know, this may be our first kind of targetable avenue for using drugs to specifically inhibit the action of FOXL2. So to do this, we first built granulosa cells that actually lack the FOXL2 mutation, and then we put them through a really rigorous drug screen. And the drugs in this screen, there's about 2,500 of them, they were all FDA approved. So we were really looking for something we could rapidly operationalize and take into a clinical trial that wouldn't go through a lot of chemical development or need sort of early phase safety data to the extent that some of these drugs were. So we found that glucocorticoids as a class here, shown in green, actually promoted the growth of these tumor cells, but only in the presence of FOXL2. It was quite a striking effect, and we demonstrated that this was specific for glucocorticoids and not closely related other hormones, and so seemed to be very specific in terms of both the involvement and requirement for the FOXL2 mutation and also the particular aspects of glucocorticoids. So to better characterize this, we actually developed a granulosa cell biobank where patients would consent for collection during one of their surgeries, and we would try to grow this tumor material as organoids in our lab. And we were successful in many cases with doing this, and characterized these tumoroids, found that they retained a lot of the characteristics of granulosa cell tumors. And we used this to kind of extend our findings about glucocorticoids and show that actually for most of these organoids, glucocorticoids like dexamethasone, shown in purple, also promoted their proliferation and growth. So demonstrating that even in tumors from humans that are more high fidelity, that we still see this effect. And so we think that what's happening is actually the FOXL2 is being reprogrammed in part by the presence of glucocorticoid to drive a more aggressive and more proliferative phenotype. And so this was alluded to in Dr. Moore's talk about, there's a drug called relacorilant that's had a recently completed pivotal study that's very promising in epithelial ovarian cancer. I did not include those data because to date it has not been studied in granulosa cell tumors, but that's certainly something we're very interested in working on, because relacorilant is a inhibitor of glucocorticoid signaling, and I think the rationale based on these data is pretty compelling for using relacorilant either by itself or in conjunction with dexamethasone-free ways of giving chemotherapy. So in summary, I want to just, the takeaways I think are that granulosa cell tumors or adult type granulosa tumors are a very unique form of ovarian cancer, and they have their own challenges in terms of treatment and their approach to this. And that there's very kind of accelerating number of clinical trials that are evaluating novel hormonal combinations for this disease. And we're trying to be at the forefront of that by providing cutting edge science and models so that we can most rapidly kind of take the most promising things from the laboratory to these new clinical trials as fast as we can. So can really move the needle for this particular disease. So I want to thank everybody, put my contact information up if there's other questions after the event concludes. But thanks Overcom and everyone for the invitation, and look forward to the Q&A.